force with the catheter, but stereotaxis offers a nice soft means of ablating tissue by being able, with digital control, to precisely position the catheter where you want it in the heart. And compared with manual, when you compare magnetic to manual, there is not a lot of difference in force on the heart tissue. And so this catheter that stays very stable on the heart tissue and moves nicely. When Mark this morning showed the nice example of the accessory pathway that was ablated successfully in his presentation, the slide where he showed the delta wave go away, if you look on that slide, the immediate, just as the heat was being delivered, not even a second later, the delta wave was gone. That's typical of good positioning with a manual ablation and their previous work also with that W or M sign endocardially when you map. But with stereotaxis, you won't see that. It's going to take a lot more seconds before you see the delta wave go away as an observation in terms of its force on the tissue. So just to continue in regards to this issue of force on tissue, I thought I would now steer the presentation towards the new force sensor catheter that is coming out. So this is the work done by the group in Switzerland on the use of their catheter that was published in December 2008. But a similar technology using a different system is ready to hit the market. So the first prototypes are going to appear in labs during the summer. There was a study that was performed using this new catheter, but it will be made available to different investigators and clinically, I guess, become available afterwards. So later this year. So now the idea is that during ablation, not only will we have impedance, power, temperature, but we're going to have contact force. So that's a new thing that we'll see for people doing ablation in the series of experiments that were performed in Oklahoma with the thigh muscle preparation of Dr. Nakagawa. They did contact force from 2 to 40 grams of tissue and applied for periods of time of 60 seconds. And you can see that when they looked at maximum lesion depth at 30 watts and at 50 watts, comparing grams of force of 2 up to 40. So this is lesion depth, lesion diameter, and lesion volume. Obviously, you can see that there's a lot more volume of ablation with greater contact force. So there may be areas where you want to record greater grams of force when you apply energy to have a more transmural lesion or a deeper lesion. There are other areas where you don't want to do that. With stereotaxis, we know as a fact that we're sitting over here around 10, perhaps pushing a little bit. We can be a little bit higher. We know we have clinical success with stereotaxis in terms of follow-up of patients who've had AF ablation. So it's very interesting to see what will be the role of contact force. I think for people in interventional electrophysiology, this is going to be a very interesting time period. So this is one of our example of patients who's having a stereotaxis merge Carto procedure. So you can see the vector of our catheter. We're recording our map, and then you can see the effect of applications of energy, and these were delivered circumferentially around the right and left pulmonary vein as an example of the application of this technique. But just to finish, it remains a difficult procedure, as we said, because of the anatomy. And I wanted to show this slide just to finish with the concept of the fact that the origin of AF, you could argue, involves the epicardial region. Dr. Downer showed very elegantly the approach to epicardial VT ablation. The surgeons, the AtriCure device, and other types of techniques have introduced a minimally invasive approach into the epicardium for AF ablation. And so is it possible that a next step will be the interventional electrophysiologist ablating epicardially? So this is an example when we published our 2006 work on epicardial maps of patients with atrial fibrillation. So this is the picture from McAlpine's textbook. We're looking from inside, so the left atrium, endocardially, our septum. So this is the map that we're used to seeing working inside the heart endocardially. And now we're going outside of the heart epicardially. You can see the LV that Dr. Downer was showing you earlier, and then you see the epicardial region here and the pulmonary veins that are coming out. And so we can map this region, and you were starting to see manuscripts come out of individuals who've gone epicardially to complete endocardial ablation. And so the epicardial structure can be mapped, and the whether it's the ganglionic plexuses or whether it's the Café regions could be mapped epicardially, obviously, as much as endocardially. And so the atrial fibrillation is boxed in this area by the pulmonary veins, by the main pulmonary artery, by the epicardial fold of tissue. This is where AF is occurring. And I guess you could argue to now we've not had a good technique endocardially to do this very, very completely, and certainly not epicardially. The results of surgery are however, interesting with the AtriCur device or other techniques, but because of its surgical nature, the question is there a percutaneous technique that could be possible? There's collateral structures, obviously. There's other things to consider, but at least the possibility is there. So I have backup slides if, for sake of time, people wanted to discuss further, but I thought I would stop with that. Thank you.
Thank you very much, Dr. Lemon. That was a very nice, informative overview of some of the key issues. I guess we have time for maybe one or two questions before we close this session.
Maybe I'll ask Dr. Lemire about the ablation frontier. You haven't mentioned it. Do you have any experience with that or any data to support its use in AFib?
Sorry, I didn't want to say the name of any company during the presentation, but the first case of, I guess their first case of PV stenosis with severe PV stenosis is coming out, and a few weeks ago at the European AF symposium, there was several investigators from the UK indicating that they had stopped using it because of thromboembolic events that had occurred in their patients. Now, obviously that's been looked at and discussed, the fact that we're delivering non-irrigated RF in the left atrium, and is it a concern? I think we have to be a little bit concerned about that, but we do have preliminary reports that were satisfactory in that regard. The work of, I was told 4 centers recently in the UK was very concerning, and they had stopped using it. Conceptually, again, it's appealing to deliver a catheter circumferentially, bring it circumferentially to the pulmonary vein and deliver with RF. We have their basic work, and very, very quickly clinically we've seen them in the clinical field with preliminary results that were good. But I think like the studies we discussed this morning, those are relatively small numbers. When we go to large groups of patients perform, obviously, that's when we're going to see how effective and safe these systems are. One of the other companies, I think, to compete directly with this catheter, has developed this irrigated catheter that delivers through a circumferential catheter. And but I think, as you indicate, these are modalities to circumferentially ablate the pulmonary tissue, and certainly we've had patients with excellent results using the PVAC system.
Okay, I think that brings us to the end of the session. Thank you very much, and we'll see you at the next session.